Hi, this is E. David Crawford from the University of Colorado. We have been following enzalutamide for a number of years when it was first introduced post-chemo in the AFFIRM trial. It then moved up pre-chemo in the PREVAIL trial. Another trial was done comparing it to bicalutamide, and now we have the PROSPER trial, which is a trial in which enzalutamide is used in the M0 castrate-resistant prostate cancer space. I'm fortunate to have with us Dr. Maha Hussain, who presented this trial just recently at GU ASCO. Dr. Hussain is a professor of medicine in the Division of Hematology Oncology and Deputy Director of the Comprehensive Cancer Center of Northwestern University in Chicago. I've known Dr. Hussain for many decades when she was at Wayne State, University of Michigan, and worked with me in the Southwest Oncology Group, heading up prostate cancer and a number of other protocols. I'm pleased to have Dr. Hussain here with us today to review the PROSPER trial. Maha?
Thank you, David. And it's truly an honor. It's been an honor working with you over the years, and it's my privilege at this moment to present the results of PROSPER, which is a phase 3 randomized, double-blind, placebo-controlled study of enzalutamide in men with non-metastatic castration-resistant prostate cancer. As a background, as you know, non-metastatic, that's M0 castration-resistant prostate cancer, is an area of an unmet need for decades with no current approved treatments. The development of metastases in this population is very predictable and is associated with increasing baseline PSA and a PSA doubling time of less than 10 months. Now, I should point out there have been trials done previously evaluating a bone-targeted therapy in this patient population, with the endpoints being bone metastases-free survival. Having said that, what's more important really is delaying time to all metastases, because that is clinically relevant, as that's the deadly phase of the cancer, with the potential to, of course, delay cancer-related morbidity, improve survivorship, and prolong overall survival. Enzalutamide significantly improved overall survival and radiographic progression survival in men with chemo-naive metastatic castration-resistant prostate cancer, which actually led to an FDA approval in the frontline setting of castration-resistant disease. Enza was superior, as Dr. Crawford mentioned, to bicalutamide in improving radiographic progression-free survival in a subgroup of patients with chemo-naive M0 castration-resistant disease. And therefore, we hypothesized that enzalutamide will delay metastases development in men with M0 castration-resistant prostate cancer who have a rapidly rising PSA. That's a PSA doubling time of 10 or less months. In the next slide, I outline the PROSPER study design, and I will begin with the eligibility criteria. As I mentioned, in addition to having M0 castration-resistant disease, all patients' imaging had to be reviewed centrally to, in fact, vet that. The men had to have rising PSA despite castrate testosterone, a baseline PSA of 2 nanograms per ml or greater, and PSA doubling time of 10 months or less. Men were stratified by the doubling time of less than 6 months versus 6 to 10 months, and baseline use of bone-targeted therapy. The patients, eligible patients, were randomized 2-to-1 to enzalutamide standard dose of 160 milligrams per day with continued gonadal suppression with androgen deprivation therapy, or placebo plus androgen deprivation therapy. The primary endpoint was metastases-free survival, which was defined as time from randomization to whichever occurred first, radiographic progression or death within 112 days of treatment discontinuation. The secondary endpoints included lists of safety, time to PSA progression, time to use of new antineoplastic therapy, which is a reflection, again, on the efficacy of the treatment, overall survival, PSA response rate, and quality of life. And several of these endpoints I will present today, but several will be presented at subsequent national and international meetings. The statistical design was based on looking for a target difference in median progression-free survival of 9 months which required 440 progression events that will give a 90% power to detect a hazard ratio of 0.72. 1,401 men were randomized starting from November 2013. Enrollment completed in June of 2017, and that's the cutoff date for the progression-free survival events that I will be presenting for you today. Now, the next slide shows the baseline patient characteristics. As you will see, the arms were balanced with regard to different characteristics. I want to point out a couple of points. The first one is that the median age is reflective of a relatively older patient population, 74 and 73 years old. And in fact, patients in their 90s in both arms were enrolled in the trial. The second point, which I'm highlighting, is the median PSA doubling time. While we asked for 10 or less months of doubling time, in reality, the median actually was 3.8 and 3.6 months, which tells you that this population was clearly high risk. And in fact, 77% of the patients on both arms had a PSA doubling time of less than 6 months. Now, as I mentioned, the data that I'm presenting to you, as I'm highlighting at the bottom here, are based on the cutoff date of June 2017, where at that time, 68% of patients were still on ENZA and 176 patients were still on placebo. That's 68% and 38% respectively. As of early February, this figure is the following: 61% of patients are still on the ENZA active arm, and then 28% are on the placebo arm. The adverse events are highlighted in here. These are all adverse events that were recorded, irrespective of attribution, irrespective of whether they were deemed related to treatment or not. As you see, overall, the differences were not big between the arms. 87% of patients on the ENZA arm had adverse events of any grade, 77% of the patients in the placebo arm. For grade 3 or greater adverse events, we have 31% of patients, that's total events, again, irrespective of attribution, 51% of the patients on the ENZA arm and 23% of the patient on the placebo arm had high-grade events. Of those grade 3 events, the column, below that, what we're showing is grade 3 adverse events occurring in at least 1% of patients in the enzalutamide group. And as you see overall, the rate of high-grade adverse events, again, irrespective of attribution, is not high. Hypertension was the most common event, and that was 5% compared to 2% in the placebo arm. Fatigue was 3% compared to 1% in the placebo arm. I should point out that adverse event as the primary reason for treatment discontinuation occurred in 9% of patients in ENZA compared to 6% in placebo. And then death due to adverse events on trial, irrespective of attribution, occurred in 3% in the ENZA arm compared to 1% in the placebo arm. The second slide, the follow-up slide, shows adverse events of special interest with regard to ENZA. As you see here, hypertension continues to be the most common adverse event in the ENZA arm. It's 12% compared to 5% in the placebo arm. Major cardiovascular events were 5% in ENZA arm, 3% in placebo arm. Mental impairment disorders were 5% versus 2%. Now, in both arms, the incidence of major adverse cardiovascular events was higher in patients who had a baseline history of cardiovascular disease, hypertension, diabetes, hyperlipidemia, or age over 75 years. So the point here is that comorbidities appear to associate with more rates of these events. Now, the progression event by type, as I mentioned, the primary endpoint was metastases-free survival, and any progression event or death within that 112-day window counted towards the progression events. As you see here, the proportion of progression events in the enzalutamide arm was over 50% less than that of the placebo arm, 23% versus 49%. The bulk of the progression in both arms was radiographic progression. However, it was 85% in the enza arm compared to 98% in the placebo arm. Interestingly, the progression sites, as you can see, are really not different between the different arms. Death without documented radiographic progression within 112 days of study discontinuation, and again, this is irrespective of attribution, basically occurred in, contributed to 15% of the progression events in the enza arm compared to 2% in the placebo arm. The primary endpoint, as I mentioned, was metastases-free survival, and as is highlighted here, metastases-free survival was significantly longer. In fact, it was a little over 3 years, 36.6 months in the enza arm compared to 14.7 months in the placebo arm. This is 22 months longer with a 71% reduction in the relative risk of radiographic progression or death with a hazard ratio of 0.29 and a p-value of 0.0001. This benefit with regard to MFS was visible and as presented here across all subgroups that we have looked at, irrespective of PSA doubling time rate, geographic region, age, baseline age at study entry, performance status, and other criteria. Time to PSA progression was similarly significantly longer in the enza arm compared to the placebo arm, 37.2 months versus 3.9 months, with a relative risk reduction of 93% and a p-value of less than 0.0001. Time to first use of neo-antineoplastic therapy, which is again a measure to indicate efficacy of treatment and tolerance of treatment, was also significantly longer in the enza arm, 39.6 months compared to 17.7 months, which is again 79% relative risk reduction with a p-value of less than 0.0001. Overall survival at first interim analysis is illustrated in this slide. The median follow-up time was 22 months, so the follow-up is not mature yet with regard to overall survival. However, there was an early trend of 20% reduction in the relative risk of death with enza compared to placebo. There will be a follow-up per protocol plan analysis of overall survival that should be happening in late spring. In conclusion, in men with M0 castration-resistant prostate cancer and a rapid PSA doubling time, as I showed you, a PSA doubling time of an average of 3.7 months, enzalutamide resulted in a clinically meaningful and statistically significant 71% reduction in the relative risk of developing metastases. Median metastases-free survival was 36.6 months with enza compared to 14.7 months, with a significant reduction in the hazard ratio and a significant p-value. Therapy was well tolerated. Adverse events were generally consistent with those reported in the prior clinical trials in men with castration-resistant disease. Secondary endpoints of time to PSA progression, time to first use of antineoplastic therapy were also significantly longer with enza than with placebo. As I mentioned, there are other endpoints that are being reported hopefully shortly. The median overall survival has not been reached in either group at first interim analysis. However, a trend suggests a 20% lower relative risk of death in the enza group compared to the placebo. With that, I would like to extend my gratitude on behalf of the team to all the patients and their caregivers and families. This was an international trial with collaborators from investigators across the world. And so I'm very grateful to all of the investigators and the study personnel. Without them and the patients, this could not have been accomplished. Thank you for this opportunity.
Great presentation. Appreciate it. This is certainly groundbreaking. We've all been waiting for something to show up here in this M0 space. This study, I just want to ask you a couple questions. This study
Sure.
actually was stopped early. Were you sort of surprised at that? And what are your thoughts about it? And what will we know about survival rate in the future?
So this is a great question, David. The reason it got stopped is because the actual metastases-free survival progression events actually were achieved earlier than anticipated. The sample size was about 1440, which is what was required. But by June 2017, the 440 MFS events were achieved. And so the study got terminated early. I think this is more of a reflection on two things, is the fact that the fact that this patient population, particularly those with lower PSA or shorter PSA doubling time, are a very high-risk population. And the other point is that with a median of 3.7 and 3.6 months or so PSA doubling time, you're really, really picking up the most aggressive of prostate cancer patient situation. And so I'm not really terribly surprised about that.
And I think it's also impressive rather, that looking at the side effect profile of enzalutamide versus placebo here in this trial, there wasn't a huge difference.
Correct. And I think that's the interesting part. Obviously, I should point out that these side effects are more likely going to favor placebo as opposed to enza, because the majority of patients on the placebo arm didn't stay on treatment longer. That would be one point. And the other point to highlight, which was a question that was discussed with regard to the contribution of death toward a progression event, to point out that this is the 15% contribution towards progression event in the enza arm is being evaluated in more details. As I looked at the different contributions, there was really no recurring theme as such there. So I'm not sure that it's something that's related to the drug, but it's being delved into a little bit more. Having said that, the patients on the enza arm are staying on treatment much longer than the placebo arm, and they are a larger sample size. They're double the volume, and a good percentage of them are older. So deaths could occur while patients on treatment and or complete treatment that could be related to just other comorbidities and so on. And as I said, as I was discussing in the discussion yesterday after the presentation, we are looking into it in more details. But when you look at actual high-grade events contributing to death overall in the study between placebo and the enza arm, it was really not that much different. It's 3% and 1%, which is not terribly different overall. The other thing that I thought was interesting is that the issue of the mental impairment disorder. Again, it's more common in the enza arm, but this is like a lump sum of all potential issues, as in cognitive function, amnesia, dementia, senile dementia, mental impairment, all of these things was not, again, hugely different between the arms.
Right. The other, sort of the other thing that was evident from AFFIRM was what appeared to be an increased risk of seizures in men on enzalutamide, and that hasn't really been borne out with a couple of the PREVAIL trial, and there were a couple seizures in the presentation you just made, but it was less than 1%, correct?
Correct, yeah. And these are, again, any grade events and irrespective of attribution, and it was less than 1%. And if you look at the high-grade events, and we were very conservative in reporting them, I requested that we report anything that occurred in 1% of patients in the enza group. There was, with regard to high-grade, not even the seizures were not really high-grade events either, in terms of high-grade events. So I think it's reassuring in that regard, because in these patients, for the patients who came off treatment on the enza arm, they were on treatment for close to 2.5 years to 3 years, almost less than 3 years, but almost 2.5 years. And so when you think about it, this is a long duration of treatment, and if there is any chance for these kinds of events to occur, they would have occurred by then, because we see them when they were reported in the metastatic disease. They were reported earlier. As you know, the median duration of treatment in metastatic castration-resistant disease is much less than what we observed here.
Well, we've been waiting for a long time for some progress in this disease state, and this certainly is exciting. And to have this major impact on metastasis-free survival and progression is significant, and I think it's going to open a whole new door for treatment. Any other comments you want to make, Maha, before I let you go?
No, other than to say that this is a great time for patients. I think it's a great time for impactful research, and I think our job is to continue to try to impact patients' outcomes further. And so I am hoping that we will develop combinations. We will move these treatments into earlier stages of the disease. As you know, you and I have collaborated forever trying to cause or lead to cure of that disease. And so I'm hoping we are getting closer and closer.
Well, I think that we're with all these new drugs out there and progress like this, you know, we recently did this radar 2 thing on therapeutic layering and building one drug on top of another. And as you well know, and I know, that cancers that we cure when we combine things, not A followed by B followed by C. And this is a major step forward. So I want to thank you, and we appreciate the time you gave us today.
Thank you very much for the opportunity. It was a pleasure.